I think right from the beginning, the early days of Seva, health came up. We began to organize women. Ila Ben Bhatt, the founder of Seva and the early pioneers, began to organize women around issues of work. But very quickly, health came into the picture. Let me give you two examples. The first members of Seva were Hatlari Kenchnar Beno, as we say in Gujarati, handcart pullers. And their issues were, as they pulled loads through the streets of Ahmedabad, the dusty streets of Ahmedabad, they often had accidents, they fractured their legs, they had injuries. And when we went to the legal system, to the courts, and asked for workers' compensation, we were told they are not workers. Second, many of the women worked right through advanced stages of pregnancy, and the way the hatlari is, the handcart is, the crossbar hits the lower abdomen, and they use their bodies, their lower abdomen as a brake. And so we noticed that many of our sisters were having miscarriages. So these kinds of incidents really forced our hand to focus on health issues of our members. Another important finding, really quite a shocking finding for us, was when we set up Seva Bank in 1974, 2 years after Seva in 1972. And when Seva Bank began to give savings and credit services to our members initially, we found that women were paying back regularly all the loans they took, but some of them were not paying back. So when we did a study to understand why they were not paying back their loan installments, we found that the major reason was sickness of self or family member. They wanted to pay back, but whatever the loan installment they had kept aside to pay back went in medical bills, doctor's bills, health expenditure. And when we looked into 500 such women who were not repaying regularly, we found that 20 of them had died. And 15 of those 20 had died due to childbirth. And this is Ahmedabad city, 1977. And this really forced our hand to take up health work, public health work, community health. And in fact, the first program we had was for maternity benefits, so that women had extra nutrition through a tin of ghee, which in our traditional Gujarati culture we give at time of pregnancy and childbirth. So a tin of ghee was given to our members, and the money for the tin of ghee was collected from the members themselves. So everybody contributed to one sister's pregnancy, and at least so that she should put on weight, and then we had the referral set up and so on. So these were the early days that forced our hand to take up health work, if you will. And then fortunately, I joined up as a young public health worker. I just finished my degree in public health from Johns Hopkins, and they were looking for someone who was ready to work shoulder to shoulder with the Seva sisters. And I was fortunate to find this slot and begin our community-based health program. There are so many things, of course, that affect health of all of us, and especially poor women. But I would like to start with work, because my understanding is that work is the lifeline for survival for poor women. As I explained to you the example of the handcart pullers, her work affects her health. I spoke about her miscarriages, and in turn her health affects her work, her health and the way she lives, her living conditions. She typically lives in small 10 by 15 room in a chali or in a village. She doesn't have proper ventilation. She may not have enough electricity. We live in dense, crowded conditions. Tuberculosis among neighborhood and neighbors is rampant. So there are so many factors that affect. First, her living conditions. Because she is poor, she cannot afford the basics of life. She may not have a toilet. She may not have a tap in her home even. She has to go to the common tap. All these things affect her health. Then, as I mentioned, her work affects her health. And we see typically for women workers in the informal economy, they get the worst work. They get work that men will not do. For example, growing tobacco, then processing tobacco, what in Gujarati we call khali, which is full of tobacco dust, where you and I could not even stand for 1 second. We'd be coughing. That is where she lives, in that environment, lives and works all her life. So work on health, health on work, and it's a very complex web of connections, which now we call the social determinants of health. When we first started working with women in Seva, all we knew is what Gandhiji taught us, that go among the people, work shoulder to shoulder, understand from them, and undertake constructive action, what he called Rachnatmak Karya. And through the Rachnatmak Karya, we began to understand their needs, their reality, their struggles. And then as the needs came up, first was the need for better, decent work and minimum wages among our BD workers and handcart pullers. So we took up work issues. The next issue was exclusion from financial services. These days we talk about financial inclusion. 40 years ago, when our members went to the nationalized banks, they showed them the door. They said, "You're not bankable." So we started our own bank. So financial was the next financial service thing that we worked on. Very quick on the heels of financial services was childcare, because all our members are women and they wanted a better future. They said, "We live hard lives, but we want a better future for our children." They also said, if we go out to work in the khali or the tobacco factory or the field, who will take care of our children? We carry them on our hip. We tie a sari between two trees. We pop them in like a hammock. They fall out many times. They are bitten by snakes or dogs. We don't hear them crying because we're way in the field. We need childcare. Childcare for us is poverty reduction. Without childcare, we cannot go out to work and earn. We cannot bring food into the house. We cannot send our older child to school because she has to take care of her younger brother or sister. So childcare followed soon after financial services, and then healthcare. Because women said, it's not enough for us to have money in our hand. What is the point of having money now in our hands and saving if whatever we save goes in doctors' bills and medicines? And that's really, the social determinants right there, which in those days, in the early days, we called the comprehensive integrated approach to poverty reduction. I think there are a couple of things. I think there are many policy makers, I refer to the former Planning Commission and so on, who, there was a resonance. People understood, people accepted the impact of these different factors on people's lives. At those days, they didn't call them social determinants. But I think what is hard for policy makers is they would keep asking us, show us the impact on health. How does it improve health outcomes? And I think, that is a valid question, but it's also a very difficult question, because there are several factors impinging, as I've tried to show, on health. Secondly, how can we show that it is our action alone? Because meanwhile, there are a lot of other things also clouding the picture, which is government interventions, private players, other civil society players, and so on. I think there has got to be a way, and I know that including with Indian Institute of Public Health, Gandhinagar, we've done case, we've done control, we've done different things. But still, it's difficult to tease out the different factors, is what I'm saying. But I think the evidence is there. There's a growing body of evidence. There are small initiatives, and some not so small, like Sevas. But I think there is a need to test out in different geographic areas and with different vulnerable communities, and then study these carefully. So I think there's a real role for action research, which is mutually enriching, which will throw up data which is objective as we can be, which can be useful for the policymakers. I think the main thing is to open yourself to the ground realities. And what I would say to public health students is what I was told: go out into the field, spend 2, 3, 5 years intensively working among people, doing your action research there. If you don't have a sense of the ground realities, and if you don't have a sensitivity to the ground realities, then it's very difficult to be a strong public health researcher.